Well, thank you, Bill, and welcome all. It's a great pleasure to bring to you an update on the epidemiology of obesity and where we stand with respect to this epidemic. I'm going to attempt to cover 4 areas in this discussion. The first is the status of obesity in U.S. adults and children and the progress that's occurring. Secondly, the challenges that remain with respect to severe obesity, and end with a brief insight and a potentially newer approach to how we may prioritize strategies in the policy and environmental domains. So to begin with, the promise is that we, at least with respect to some populations in the U.S., have achieved a plateau. In women, it's clear that there's a plateau regardless of ethnicity. In adult men, there's quite a different pattern. Obesity is continuing to increase and increased by 7% over this 12-year period. These data are the National Health and Nutrition Examination Survey, a continuous survey conducted by CDC and grouped in 2-year increments to achieve an adequate population for comparison. What this graph does not show is the disparities that exist. There are very significant disparities among women. The highest prevalence is among African American women. 50% of African American women are obese. About 40% of Hispanic women are obese. About 30% of Caucasian women are obese. Whereas in men, it's pretty flat across all major ethnic groups. Also, what this graph doesn't show is a common misunderstanding of the relationship of poverty to obesity. It's widely believed that poverty is related to obesity, but in fact, that is only true in Hispanic and African American men, where there is, surprisingly enough, a direct relationship with obesity. The higher income men, Hispanic men, and African American men have an increased prevalence of obesity. There's also an inverse relationship in the prevalence of obesity among women, but that's largely driven by white women, in which there's an inverse relationship. And although it's widely assumed that this socioeconomic relationship exists, I think that people tend to confuse ethnicity with poverty. And it's very important to understand that distinction because the solutions are quite different. In children, there's a bit of a different relationship. As this slide shows, the prevalence has also been flat in girls over this almost 12-year period, continuing to increase in boys. And interestingly enough, if we remove African American boys from this analysis, the prevalence in boys is also flat. So increasingly, this epidemic in children is driven by ethnicity. And in children, in contrast to what we saw in adults, there's an inverse relationship with socioeconomic status, but only in white boys and white girls. There's no significant socioeconomic relationship between obesity in African American boys and African American girls. When we look more intensively at young children and children in potentially high-risk populations, primarily those engaged in WIC, we also see a flattening of the trends. And we see this in every group but American Indians and Alaskan Natives. And the data that Harvey was referring to are shown here. These show that there are significant decreases in obesity in 18 states and 1 territory, the Virgin Islands. Statistically significant increases in obesity only occurred in 3 states, Pennsylvania, Tennessee, and interestingly enough, Colorado, which has in general been spared the adult prevalence of obesity. What we don't know yet, and I think that analyses will be forthcoming, is whether these decreases in the prevalence of obesity in low-income children are evenly distributed across ethnic groups. That analysis has not been done. Now, what's so promising about childhood obesity is that there are now 6 states and 13 communities that are reporting decreases in the prevalence of obesity, in addition to those state-based data that I showed you. There's a lot that we don't understand about the data that support this assertion. One of the first is how valid were the data collections? Were they measured data? How replicable were the data or the populations on which these data were based? In those areas in which there seems to be a real decrease, what drove those increases? What accounted for the decreases in the prevalence of obesity? And that brings us into a very interesting area in how does one assess the dose of public health interventions that may be being implemented in these states and communities. The other important concern here is that where ethnic data are available, it appears that the major changes are occurring in white populations, not African American or Hispanic populations, although there are a few places where the decreases are across the three major ethnic groups. That represents not only a concern, because as decreases in the white population occur, it broadens the ethnic disparities. But the other opportunity here is in those communities where changes are occurring across all three major ethnic groups, there is an opportunity to understand how we target these interventions in a way that reduces the disparities. Now, these data all beg the question for why these changes may be going on, and I'm fond of pointing to the tobacco epidemic as a model for how we might begin to understand what's happening here. As you can see here, per capita cigarette consumption began to increase in 1900 and continued to increase up until the 1950s, when there was the first report linking smoking and cancer. Tobacco use peaked at the time of the first Surgeon General's report in 1964, and then plateaued for a number of years before a variety of initiatives kicked in. And these initiatives were largely policy or environmentally based. Now, the important point here is that this plateau occurred in advance of any of those policy initiatives. It occurred because of, in my view, because of an increased awareness of the adverse effects of tobacco use. And people began to change those habits in much the same way that I think people are beginning to change their habits around food and beverage consumption. We're seeing decreases, for example, in the consumption of pizza, which is the second most important contributor to caloric intake in children and adolescents. We're seeing decreases in fast food consumption. We're seeing decreases in soda consumption. Across the population, these decreases are pretty modest, but may account in the early stages for the plateau that we're seeing. But the other important lesson from the tobacco epidemic is that the changes didn't begin at the federal level. They began at the local level or at the state level, in much the same way that I think we're beginning to see those changes at the state and local level with respect to the prevalence of obesity. So these are all very optimistic observations, with exception of the concern about what's happening in men or boys. But the other significant concern is that the prevalence of severe obesity, defined here as 120% of the 95th percentile in children and adolescents, is increasing. And you can see here that in the neighborhood of 6 to 7% of children and adolescents, adolescent girls, have severe obesity. And we're also seeing those same increases over time in boys. And if you look at both this slide and the last slide, you can see that those disparities in terms of ethnicity are already present in girls and reflect the kind of ethnic disparities that we're seeing in adult women. And in contrast to men, there's a much higher prevalence of severe obesity in non-Hispanic blacks or African Americans and Hispanic youth. The same trends are occurring in adults. Severe obesity during this period of NHANES increased by about 30% in both men and women. Now, the importance of severe obesity is that this is not a problem that is going to go away with the kinds of policy and environmental initiatives that are being pursued. Those address a relatively small caloric deficit, which is what is necessary for prevention. But these data suggest that unless we also institute a clinical approach to obesity, to treat those who are already obese, particularly severely obese, we're not going to make much of a dent in the epidemic of the people who are driving those costs. And as this shows, that disparity that we saw earlier in African American women persists in the development of severe obesity. Now, the costs of obesity are significant. These are conservative estimates which we published in 2009, which showed that these costs doubled over this period and accounted conservatively for 9% of the national health care budget at this time, and that Medicare and Medicaid accounted for almost half of these costs in the population. And it's clear that these costs are generated by the more severely obese, and that's nicely shown in these data from a study by Arterburn. This wasn't in this pie chart was based on data that he published. This was not an analysis that they did in this study. But as you can see here, grade 2 obesity, which are people with a BMI of 35 to 39.9, and grade 3 obesity, which is a BMI greater than or equal to 40, account for about 8% of the population, but 40% of the cost. And the promise here and the challenge here is that we don't currently align the intensity of our therapies with the severity of obesity, either in adults or in children. But these data suggest that if we're going to make a difference in the cost of obesity, we really need to focus innovative forms of treatment on this population. And the standard approaches to therapy are ill-suited to address a problem that has this type of prevalence. And that suggests that with the advent of ACA, and if we're going to be effective in treating severe obesity, then we have to change the way we deliver care. We have to think about care extenders. We have to think about groups. We have to think about ways of joining clinical and public health approaches in a way that we haven't done. We have to think about interprofessional education. So that, for example, there are very few medical schools, and I suspect nursing schools and dietetic schools, that teach providers how to begin the discussion of obesity, what terms to use that are not offensive, there are very few places which are directly addressing the bias associated with attitudes towards overweight and obese people, and we know already that those attitudes and those biases affect the quality of care. Now, the reason we were successful with tobacco and have had ongoing success is that we've focused well beyond the individual. We've focused on federal, state, and local taxes. We've set policies, tobacco-free policies within communities. There's a spread of tobacco cessation along social networks. We've established institutional strategies, and those strategies at the top of the social ecological model are going to have the greatest impact compared with those which are individually focused. But we need to, and this bespeaks the need for a multi-layered, multi-sectoral approach in much the same way we address tobacco. But like tobacco, we need to think both about the clinical equivalent of tobacco cessation, which addresses smokers who have trouble quitting, as well as preventing smoking in the first place. In much the same way, with respect to obesity, we have to prevent obesity in the first place and develop better strategies for those who are already overweight. And I think we're at a point where we can begin to be much more discriminating in terms of the strategies that we elect for at least prevention. These are data that Claire Wang published a year ago, which I think provide not only optimism, but also an explanation for why we're seeing shifts in the prevalence of obesity, particularly among young children. She estimated that the energy deficits necessary to achieve the Healthy People 2010 goal, which was a prevalence of 5% back where the mean BMI was in the 1970s, is pretty small among 2 to 5-year-old children, about 30 calories. 150 calories among 6 to 11-year-olds, about 180 among 12 to 19-year-olds. These are achievable targets for reversing the epidemic by returning the mean to where it was. These are much smaller deficits than those necessary to achieve weight loss in children and adolescents who are already obese. Interestingly enough, there's the comparable number for adults, which returns them to a prevalence of about 10%, which is where they were in 1978, is about 220 calories per day. And again, these are achievable with the types of strategies that we and others have begun to implement, first at the CDC and then implemented within state programs and elsewhere. The only two targets here which are likely to respond to that individually based approach are pregnancy, where we know that pre-pregnant weight gain, diabetes, and tobacco use increase the likelihood of early childhood obesity, and sleep, which is a family-based behavior. But these other strategies, the reduction of energy-dense foods, the increase in low energy-dense foods, reduction of sugar drinks, television time, breastfeeding, and increased physical activity are all strategies which can be implemented in a multi-layered, multi-sectoral approach. But to say that, which is what CDC said when we first funded the CPPW programs, the Communities Putting Prevention to Work, resulted in hundreds of strategies aimed at trying to shift these. And I think based on Claire's data, as well as some other insights, we can begin to narrow the target for obesity prevention efforts by beginning to estimate the caloric impact of a policy intervention. And here are a couple of samples of what might happen if we applied the California standards, which are now the national USDA standards for competitive foods. That might save as many as 80 calories a day. So that would be half of what the deficit needs to be in 6 to 11-year-olds. If we eliminate sugar drinks or switch from whole to low-fat milk in early care and education centers, that's another 80 calories, well in excess of what we need to achieve for that youngest 2 to 5-year-old age group. And the data on fast food consumption, if fast food consumption is decreased and not compensated, is 125 to 310 calories per day. On the physical activity side, these data are expressed in minutes of moderate to vigorous physical activity on a daily basis as a caloric equivalent. Mandatory PE may account for as much as 23 minutes a day of increased physical activity. Classroom breaks about 20 minutes, and walking and biking to school for that 20% of the population that's capable of walking and biking to school would increase moderate to vigorous physical activity by about 16 minutes. So I think if we begin to think in these terms of being able to attach a caloric cost to an intervention, I think that we can begin to narrow the focus of the policy interventions. But this is only the first step. Right behind that is the cost effectiveness of these policies. And there's some beautiful work being done by a program called Choices in Boston by Steve Gortmaker and his group. Choices stands for Childhood Obesity Interventions and their cost effectiveness. And what they've done is to analyze the reach, the cost, the BMI unit decrease, and the cost per BMI unit decrease of 4 strategies. This is ultimately going to be expanded to 20. And those include a sugar drink excise tax of a penny an ounce, active physical education in schools, elimination of the tax deduction for TV advertising, and implementation of multiple early care and education policies. And you can see here that the cost per unit of BMI decrease is pretty modest. The least expensive is TV advertising. The most expensive is active PE in schools, which involves an investment in teachers and infrastructure. But what's also important here, and one of the things to think about, is that both an excise tax and a TV advertising change are not only effective strategies for decreasing BMI, but they're also a source of revenue. So there's a double benefit from the implementation of these strategies. Now, in the talks that follow, you're going to hear about progress in these settings for the prevention and treatment of obesity. Early care and education, schools, work sites, healthcare, which includes healthcare delivery systems and hospitals, community and states, the federal government, and business and industry. And I think that it's clear that there's motion and I think evidence of progress in each of these areas. And it may be most appropriate to close this discussion about where we are with the obesity epidemic with a quote by Winston Churchill, who said, "This is not the end, this is not the beginning, but perhaps it's the beginning of the end. Thank you. Actually, I think I had the quote wrong. It's the end of the beginning.